right. Well, welcome everybody. Good morning on this cold February morning now. Glad to see you all here. We have a special ground rounds this morning. We have Ben Pedroja, who's our current chief resident, who's going to give us a talk about buprenorphine in the hospital, a very important topic. Ben attended Reed College for undergraduate, and then he went to the State University of New York for Upstate Medical University for his medical school. He completed his residency here with us, and he's now serving as the chief resident, where he's proven to be one of the most curious and intellectual and effective teachers that we've had in a long time. And we're glad to hear his talk this morning. After Ben finishes his chief resident year, he's going to stay on with us as faculty and as a hospitalist here at PPMC. So Ben.
You guys hear me okay? All right. Well, thank you, Jesse, for that kind introduction. Jesse, of course, will always hold a special place in my heart. He was chief when I was an intern, and so I feel like we've completed some kind of cipher here this morning. It's my great honor to stand before you here today. The title of my talk is Buprenorphine in the Hospital, Expanding Access to Life-Saving Treatments for Opioid Use Disorder. I'd like to take a few minutes to talk about why I chose this topic and what I'm hoping to achieve. And so I think it's no mystery to all of us. We're in the midst of an opioid epidemic of unprecedented proportions. It seems like each day we're surpassing some new heights or perhaps some new depth. And so clearly this is something that we all need to take very seriously and work towards improved outcomes. And it seems like this medicine, buprenorphine, I keep hearing about again and again, and something that perhaps serves as a model as we move forward in how we confront this epidemic. And not a couple of years ago, our very own Mari Kai and Brinton Clark stood at this very podium talking about some of the work they were doing, expanding outreach to some of our Providence clinics and getting more and more providers waivered with buprenorphine. And so I thought it would be a nice project to see what it amounts to try to expand access to some of our hospitalized patients. As Jesse mentioned, I'm very proud to stay on as a hospitalist here at PPMC next year. And so I thought this would be a really nice opportunity to expand my scope and raise awareness for this very important issue. So with that, I'll get started. Thank you all for being here. And without further ado, so I have no financial disclosures. I'll start off with a case. So this is Jason, a gentleman I met a couple of years ago. Long history of opioid use disorder. He was admitted with endocarditis. And this is his film here on the right. You can see he's got the classic cannonball appearance of multifocal pneumonia from septic pulmonary emboli. And he was pretty sick with this. Really bad cough, fever, hypoxic, all of it. And this led to some difficulties with his withdrawal management. He was really terribly painful and symptomatic, but we couldn't up-titrate his methadone dose, which we had chosen to use to manage his withdrawal, because of persistent issues with sedation and hypoxia. He seemed to be alternately somnolent and violently agitated with staff, and we ended up having one behavioral contract after another signed and revised. It was a sort of daily battle with the staff there up on 5G. And ultimately, it was with some frank relief, actually, that he discharged against medical advice after getting 8 days of IV antibiotics. So clearly not an outcome that we would all hope for Jason. And so I think this kind of animates my talk to an extent, is can we do something different? Can we manage this better to try to change the outcome for patients like Jason, who I think all of us can relate to in some way or another? So I have a few learning objectives. I'll listen here. Opioid use disorder is a chronic disease. And it's really important that we change the way we think about this disease. As I'll hope to convince you, it really impacts our care. And so reframing this disorder as a chronic medical illness, I think, is very important. I want to emphasize that effective treatments are available, but are vastly underutilized. And then, of course, I want us all to recognize that hospitalization really is a reachable moment for these patients who often are really not engaged in the healthcare system in other capacities. And so it really presents a pretty unique opportunity for us, and one that we ought to take advantage of. I want to talk about buprenorphine, mechanisms of action. I want to detail the process of induction. And I want us all to appreciate some of the key considerations for hospital-based treatment. So this is a graph I think we're all familiar to all of us, plotting overdose deaths here from 1980 to 2016. As you can see, there's just this meteoric rise from less than 10,000 in 1980 to almost 60,000 in 2016. And that number is now higher than 70,000 in 2017. And to put this into some perspective, that's in fact more deaths than the entire Vietnam War on the American side. And that's a yearly death rate. Some other notable benchmarks here. We've surpassed peak HIV-related deaths, which was back in 1995. We've also surpassed the peak car crash deaths, which was back in 1972. And so now we're dealing with an opioid epidemic that is the most common cause of death in our young people in this country. So this, again, is breaking it down just by opioid overdose. So I'm plotting overdose deaths by from 2000 to 2015. The green line here is all opioids. You can see it going straight up. A couple things I would point out. The purple line here, these are prescribed opiates. So you can see they're kind of leveling off here. But over this period, we're seeing a precipitous rise in heroin overdose. And then look at this. This is fentanyl. Newcomer here going straight up over the last several years. So thinking about hospitalizations, this is the rate of inpatient stays from 2005 until 2014. The blue line here is hospitalizations. The green line is ED visits. You can see a general trend towards ever-growing numbers. And if you compare Oregon nationally, it turns out we rank 9th in the nation at 307 per 100,000. Maryland takes the top slot at 403, and the bottom down here is Iowa, it turns out. So it's a little secret to all of us. Opioid use disorder complicates our hospitalization. I've seen estimates as high as 1/3 of all our inpatients have some form of non-alcohol substance use disorder. And of course, this is associated with poor outcomes pretty much across the board. Increased length of stay, increased readmissions, increased morbidity, mortality. And some estimates put the rate of against medical advice discharges at 1/3. So what's the typical approach? I think mostly was taught in residency, and what we see on the wards commonly is to initiate some kind of rapid taper, try to get these folks off of narcotics. I think we all agree that cold turkey is now kind of a cruel and unusual way to manage this. And so often we're going to be reaching for methadone and contemplating some kind of rapid taper. But what we know is that detox doesn't work. So here I'm plotting patient-reported abstinence over the first 30 days after detoxification. And what you can see here is that almost 90% by the end of 30 days are going to relapse. It just doesn't work. And not just that, but in fact, post-hospital discharge is one of the highest risk periods. And so here I'm plotting drug-related death rate per 1,000 as it pertains after discharge. And so this big red bar here is the first 28 days. And as you can see, as compared to folks who were not admitted to the hospital, there's better than a 15-fold increase in opioid-related deaths. And the hypothesis here is that as we initiate a detox program in inpatient, patients are then returning to their prior habits as outpatients and are accidentally overdosing because of the loss of tolerance. And so not only does detox not work, but I think it sets us up for a particularly high-risk period post-discharge. And so we really ought to be thinking elsewhere on how do we manage this condition in the hospital. And I think the paradigm that comes forward is this idea of long-term treatment, what's often called medication-assisted treatment, or MAT. And I've listed some of our options here. I'll take a minute just to talk about naltrexone. I'd like to table further discussion for now. That, of course, is an opioid receptor blocker. And it doesn't have a big role in the hospital setting because you need to be completely abstinent from opiates for a week or more in order to use that medicine. So it just doesn't fit with the population that we tend to see. So I'll table further discussion for now. So thinking about how are we doing? How well are we doing in getting these folks into treatment? So in 2016, there was an estimated 2.1 million people afflicted with opioid use disorder. And as you can see, only 1 in 3 had any form of treatment whatsoever in 2016. That means there's fully 1.5 million people with this condition who aren't being treated at all. So what about the hospitalized setting? This was a 10-year retrospective review from a prestigious medical center out in Massachusetts, where they looked at every inpatient who was admitted with endocarditis over that review period. They had about 100 patients. And they found that only 8% had any plans for medication-assisted treatment at discharge. Almost 50% were readmitted during the review period, and 25% were actually deceased at the end of this review period. So I think we can all agree that suboptimal is perhaps the lightest of terms that can be applied to how we're managing opioid addiction in the hospital. And this is a common parallel that's often drawn. If someone comes to the hospital with a foot that looks like this, you're going to do a few things, probably a lot of the same things you're going to be doing with our friend Jason we talked about. You might think about antibiotics. You might think about calling a subspecialist. But we're also going to make some real strides, or at least attempts, to address this poorly controlled diabetes. You might refer this person to diabetic education. You're going to do a lot of work trying to get an anti-glycemic regimen that's going to work. Yet, as it applies to a patient like Jason, we really only make gestures towards addressing the underlying cause, and somehow that's okay. And so the question then becomes, why don't we treat addiction? And so a lot of times you hear things like this, as if it's somehow a choice, that a patient with opioid use disorder wakes up in the morning and decides to continue abusing drugs. And if we're thinking of this as a choice, it's really kind of putting the blinders on as to the real causes of this disorder, and doesn't do us any favors as we think about managing this difficult condition. So this was an anonymous survey from that same prestigious East Coast university, where they asked general internists, about 300 of them, 30% of whom were hospitalists, and fully 95% found these patients to be difficult to care for, a sentiment I think we can all relate to. 80% felt that caring for patients like Jason was less satisfying than some of their other clinical activities. A third, 28%, felt that medication-assisted treatment was just replacing one addiction for the other, and only 5% felt prepared to even discuss treatment options. So again, returning to our patient, Jason here. He was clearly in a moment of crisis. Looking back at his chart, you see a distinct pattern of hospitalization, difficult interactions with staff, and so he really only comes to us when he's in real crisis. And clearly that was the case this time. And he faced a healthcare system that was distrustful and frankly punitive in its care for him. He was discharged back to the street. He's a homeless guy, really with minimal support, and likely returned immediately to intravenous heroin use. And I think none of us would be surprised to learn that he was readmitted a short time later with bacteremia and continued complications with infection. And so again, this cycle of hospital readmission is one that I think hospitalists are uniquely positioned to try to address, and I think I'd like to spend the rest of my talk today understanding how it is that we might be able to break this cycle. So this is the question, really. What can we do as hospitalists? And the first one I touched on already, which is to reframe how we think about addiction. That is to say that addiction is a brain disease. It has genetic, environmental causes, just like the other diseases that we're used to thinking about. Clearly there's a genetic susceptibility. We have well-documented neuroplastic changes, particularly in the prefrontal cortex, as it relates to executive function, impulsivity. And obviously, I think we can all agree that it's behaviorally, culturally, socially mediated disease. So it is really a chronic disease, and we should think about that way. And so here on the right, I've plotted a classic schematic for a relapsing chronic disease. And so we have cardiac function here, plotted over disease progression. And what we can see is these recurrent decompensations, where a person may be admitted to the hospital with an ischemic event or a heart failure exacerbation, for example. They may then return to their prior baseline with a general trend towards ever greater disability. And I think we could change the labels on this graph perfectly well to read addiction and risky behaviors or something like that, and it would apply just as easily. And so again, reframing this idea as that social dysfunction and the risk that we see with these patients are symptoms of the primary illness, and that these decompensations, when they land in the hospital, they should trigger additional support from us, not less, which is so commonly seen. So this is an interesting study from JAMA in 2000, where we're looking at the rate of relapse here, comparing drug addiction to some of the other common chronic diseases that we manage. As you can see, relapse rates are high, no doubt, but they're in fact not at all different from asthma, hypertension, type 1 diabetes. The difference is that when someone with drug addiction has a relapse or decompensates, their life gets turned upside down. They lose their house, they land in the hospital. Someone with hypertension, they walk around with high blood pressure for a little bit. And so I think it's important for us to think about this and understand that, yes, relapse rates are high, but this is part and parcel with management of chronic disease that we all deal with day in and day out. And this is another topic I want to touch on, this idea that words matter. How we talk to each other, how we talk to patients has a big impact on how we approach this problem and how we manage this terrible disease. And so I put a table up here of some of the things we ought to be avoiding. Harmful labels like addict, user, drug abuser. Instead, we should be using patient-first language, a person with opioid use disorder, a person with addiction. Move away from talking about urine as being clean or dirty instead of a negative or a positive test. Similarly, talking about remission and recovery, not being clean. This one I find the hardest is to move away from descriptions of relapse and using instead words like return to use. But I think it's important, and as I've prepared this talk and been working on this project, talking to a lot of folks about addiction, this requires a real active element on our part. It's not going to happen by itself, which is why I'd like to take a few minutes to show it to you guys as something that we ought to be moving towards. So, returning to this question, reframing how we think about addiction, but also recasting our role in the treatment of addiction. And so what do I mean by this? So here I've got a cartoon. The sink's running, it's overflowing, a bunch of water on the floor. I think these are a couple of hospitalists here, mops in hands, mopping up the water. And so I think the idea being we should put these mops down, turn around, and turn off the spigot. And that's a nice analogy to, yes, we need to treat endocarditis, infections, whatever else, but we ought to also be trying to get at the root cause, just like we would for that person with a diabetic foot. So this was a survey of hospitalized patients with opioid use disorder. This was actually done by Nora Englander up at OHSU. She found that fully 2/3 of inpatients would like to cut back or quit. Almost 50% had a strong interest in medication-assisted treatment. And so I think there's real cause to think that patients are ready for this kind of change. And as hospitalists, I think we're well positioned to help us along in this direction. So this was a nice case that was actually just published 2 weeks ago in JAMA. They described a complicated situation with a 21-year-old female, not at all unlike our friend Jason, admitted to the hospital with endocarditis, ended up needing a valve replacement, but they were able to get this person on treatment, discharged into long-term care, and she's now a peer mentor helping other people struggling with addiction towards recovery. And so again, I think this is the kind of treatment model that we're seeing come together. And I particularly liked this quote, which is that hospitalization is a critical opportunity to move beyond treating the sequelae of opioid use disorder to treating the primary illness. And so again with this question, I think really what we ought to be doing is to reorient towards long-term treatment. Using our position in the hospital to really think long-term about recovery as being the most effective treatment. And so really this is what we're talking about, medication-assisted treatment. And I'll just take a minute here to talk about methadone briefly. This is something I think we all know about. It's been around for generations. And so I'd like to focus our talk really on buprenorphine, as even though it's been around a long time, is relatively little known. And I think something that we ought to be utilizing more so. And so the pictures I have here, we have several very attractive things about buprenorphine. Some of the pharmacology I'll get into, but also the fact that it can be prescribed as part of a patient-centered medical home, which fits with this change in thinking and attitude that I've been getting at as we approach patients with addiction. So let's drill down on buprenorphine a little bit. So it is a partial agonist. That is to say, as it compares to a full agonist, which is methadone is the kind of example here. When methadone binds a receptor, it produces a full agonist effect. When buprenorphine binds the receptor, the fit isn't quite right, and so you get submaximal activation of that receptor. And that has some important impacts, as we'll see. And the effect that it has is some mild analgesia, but typically doesn't have the euphoria that we associate with full agonists. And the effect is really to reduce withdrawal symptoms and reduce cravings. And so this submaximal activation produces a ceiling effect that I want to talk about in some detail. So here I've plotted opioid effect over the log dose. And so comparing a full agonist, which is methadone in red, as you increase the dose, you get ever greater activation of that receptor. Similarly, naloxone, which is the receptor blocker, you get no opioid effect as the dose increases. But with buprenorphine, as the dose increases, you reach a point at which further dose increases do not produce higher effects. This is the ceiling, and this has some important implications. Mostly, the biggest one really is that the psychomotor depressing effects and the respiratory depression turn out to be above this threshold. So you really don't get those side effects that we all struggle with so much with methadone. And one of the important implications here is that virtually all reported overdoses involve multiple substances. So buprenorphine is safe. I want to talk a bit about SUBOXONE. This is the trade name that you're most likely to encounter. This is a buprenorphine naloxone combination pill. It's important to understand that naloxone is added to reduce misuse. It is not absorbed, it is not active when used properly by the sublingual route. It's added so that if you crush up the medicine and inject it, the naloxone will be active, it'll displace all the opioids from your receptors, and you'll immediately go into withdrawal. And you might think twice about doing that again. So, also importantly, buprenorphine is known to have positive impacts on our patients. It reduces IV and illicit use. It reduces infection, HIV, hepatitis C transmission. It reduces bacterial infections as well. It's even been shown to reduce some criminal behaviors that we see so commonly in this patient population. And not just that, but it reduces all-cause mortality. This was pooled cohort studies from a systematic review in BMJ in 2017. It was about 15,000 patients, dominated by one large cohort in Australia. But what they found is that compared to patients who don't receive any kind of addiction treatment, the mortality in folks treated with buprenorphine is less than half of that. And so this is important for us to keep in mind as we think about this medicine. But again, the task today is to think about hospitalized patients. Of course, these were mostly outpatients who were visiting primary care clinics or detox centers requesting treatment for their addiction. The topic for discussion today is hospitalized patients who didn't come to the hospital for their addiction, they came for something else. And so what do we have in terms of data coming out in this particular population? And we're starting to see some trickle out. So this was a study published in JAMA in 2014, getting at just this question here today. Often called the STOP study. This was a prospective randomized controlled trial. These were hospitalized patients with opioid use disorder who were admitted for a reason other than addiction, infection, overdose, or whatever it might be. And so essentially what they did is they had research staff approach each patient who met inclusion criteria, have a conversation about medication-assisted treatment, and if the patient was willing to engage in treatment, they would then be randomized either to a 5-day buprenorphine taper, which is a standard protocol, or induction in the hospital with dose stabilization and facilitated linkage to long-term outpatient treatment. That is to say, again, research staff would meet with the patient individually and make sure we had plans for treatment post-discharge. The primary outcomes were entry into treatment post-discharge and sustained engagement at 6 months. So looking at some of their data, I'm showing you the percent of patients who engaged in treatment post-discharge. As you can see, folks who were randomized to the linkage group, these were the folks who had research staff helping them find providers post-discharge, 72% of them actually engaged in treatment, and that compares to 12% of patients who were randomized to the detox group. Now, reality is reality, of course, and so at 6 months, this number is down to 16%, still engaged in treatment. But again, compares favorably to the 3% of patients randomized to detox. So this number I want to take a minute to think about a little bit. It's actually lower than most of the published estimates for treatment retention with buprenorphine. And the thought is that this is a very different patient population than most of the data we have about buprenorphine. Again, these were hospitalized patients who were not seeking treatment. And so while this number might seem low, I think it suggests to me at least that's 16% of patients who never would have been treated at all under any circumstances. So that's a victory in my mind. And not just that, but there is a bit of a silver lining, where even at 6 months, self-reported illicit drug use was down 40% among patients randomized to linkage. So this is kind of a new model that's been put forward. And I like this title. This was a perspective in the New England Journal in 2016, where they say, putting parity into practice, integrating opioid use disorder in treatment in the hospital setting, which is really what I think we ought to be working towards. And since the STOP study came out, we're seeing several large case series getting put out. 40 patients, 47 patients, and we're seeing similar kinds of numbers as people retained in treatment. And so in my mind, this really kind of charts a path forward for us. And so I'd like to talk a little bit about how we might replicate that here. So the first question that often comes up with this medicine is it legal? And as many of us probably know, to prescribe this medicine outpatient, you need a special waiver from the DEA. And there are limits on the number of patients you can treat with this license. On the inpatient side, though, there was no requirement for a waiver. And this includes new starts of buprenorphine. And in fact, it's legal to prescribe up to 72 hours of medicines at the time of discharge. Excuse me. Oh, and I'll call your attention to this website. This is the Substance Abuse and Mental Health Services Administration website. It's actually a great website. It doesn't appear to have been affected by the shutdown. There's lots of very helpful information about where to get your license training, all the legalities of these sorts of things, all very easy to find right here on their website. So I would call your attention to samhsa.gov. Okay, so before starting buprenorphine, it's important to have a conversation with the patient, emphasizing choice and alternatives as we have this conversation. Detail some of the risks and benefits, which I'll try to get to here in a moment. And it's important to understand that there's other concomitant substance use disorders as well. There's a few screening labs that are recommended. Buprenorphine, in rare cases, has been associated with some liver injury, and so it's important to establish a baseline LFTs. Also, for the same reason, it's recommended to screen for hepatitis B and C, and of course, HIV. And it turns out that naloxone is contraindicated in pregnancy, and it's important to establish whether or not someone is pregnant before considering this medicine. So, you've had your conversation, we're ready to go. What's the actual process? So on day one, the first thing we got to do is to stop all narcotics. And then we have to monitor on what's called a COWS protocol. I'd like to take a minute to think about what this is. So here I've just got the basic schemata of withdrawal, showing you that within 6 to 12 hours after the last dose, you're going to start to see symptoms like nausea, vomiting, stomach cramps, diarrhea, goose flesh, all the sorts of things we commonly associate with opioid withdrawal. And the COWS protocol is really just a scoring system. So here we've got GI upset, for example, goose flesh, all on down the list. You get a score for each one of these. It's kind of like CWA for opioid addiction. Essentially tells you, in ideally objectively as possible, how severe their withdrawal is. And so once their COWS gets to 12 or greater, then we can go ahead and give our first dose of buprenorphine. And 4 milligrams is the recommended initial dose. And the reason that we have to wait until the COWS is greater than 12 is to avoid what's called precipitated withdrawal. So we're turning to our graph here of opioid effect over logged dose. If someone's taking heroin, for example, a full agonist, they're going to exist somewhere up here on this graph. If you then treat them with buprenorphine, which we know is a partial agonist and binds very tightly and will displace a full agonist, they can go quickly from here into here. And you'll see immediate signs of severe withdrawal. So that's why it's so important to make sure there are objective signs of withdrawal prior to starting buprenorphine. So we're turning to our induction protocol. So once you've given that first dose of buprenorphine, you're going to want to reassess within a couple hours. And consider giving an additional 4 milligram dose. And we don't have COWS targets here. This is really a subjective assessment is, are we still having a ton of symptoms? Are there still a ton of cravings? And you can actually give a couple of doses on that first day if you need to, up to a maximum daily dose of 16 milligrams on that first day. So on the second day, you give the total dose from day 1 as your starting dose for day 2. And then you reassess every 6 hours or so, and you can consider giving an additional 4 to 8 milligrams of buprenorphine, again, for symptoms or cravings as you see fit. And then the process repeats. So on day 3, you start with a total daily dose from day 2, and in general, most patients will have stabilized on a dose by now, but you can give an additional 4 to 8 milligrams if needed, up to a total maximum dose of 24 milligrams per day. So that's the easy part. The process of induction itself is relatively straightforward. So I'd like to spend the remainder of my talk thinking about some of the other barriers that we commonly encounter. And so I've listed some of them here, and I'd like to discuss these in turn. So this first one we've already touched on a little bit, but I really can't emphasize this enough. One thing that we haven't talked about is, yes, the relapse rates are very, very high. But not unlike tobacco cessation, what we know is that this pattern of relapse is fully expected with this disease. And in fact, there was a post hoc analysis of the STOP study that was published a couple years later, where they looked at demographic and other information to see what may have predicted treatment retention at 6 months. And it turns out that prior treatment with the buprenorphine was a predictor of future success. And so even if we are going to anticipate relapse rates up towards 70%, that's still a benefit and is perhaps setting that person up for success at some point. So there are a few comorbidities that we need to think about, and I'll discuss a few of them now. So, as I mentioned, if someone is very, very sick, for example, they're septic or unstable for another reason, you need to have some signs of withdrawal before starting this medicine, so they may not tolerate that, in which case they're probably not a good candidate for buprenorphine induction inpatient. Similarly, if someone has a severe psychiatric disturbance that would preclude daily dosing, you're setting that person up for a difficult withdrawal pattern, and they're probably not a good candidate either. I already mentioned the liver injury. Buprenorphine is cleared by the liver, and so if somebody has severe liver failure, it's probably not the best time to induce buprenorphine. I'm talking severe, with LFTs or liver-associated enzymes greater than 5 times the upper limit of normal. The last one I would want to mention is concomitant substance use disorders. And this gets a lot of attention. And so I want to touch on this a little bit. So in the initial package insert for buprenorphine way back in the late 90s, there was this comment that simultaneous benzodiazepine use was associated with increased risk of coma and death. And this made its way into guidelines going forward. And so for a long time, benzodiazepine use has been a relative contraindication for buprenorphine. But as it turns out, this risk has been overblown to some extent. It really came out of some autopsy studies in the 90s out in France, and it hasn't been replicated significantly. And we also have pretty large registries from our own VA, and there's some in Australia as well, where the estimated simultaneous prescription of buprenorphine and benzodiazepines are upwards of 10–15%, and yet we're not seeing huge rises in overdose deaths and coma in that population. So while I'm not at all recommending that we kind of continue on layering CNS depressing medicines, I think this contraindication should be considered a little differently. And actually there's been an update from the FDA in 2017 where they say that the risk of untreated opioid abuse likely outweighs the risk of simultaneous buprenorphine and benzodiazepine use. And so I would submit that I don't think this represents a contraindication. So pain management. Obviously, this is a vexing problem. And this probably represents the single greatest barrier to widespread adoption of this medicine in the hospital. And this is a big problem just more generally. So backing up for a minute and just thinking about pain management in patients with opioid use disorder in general. And I would introduce this term, opiophobia. This is the tendency to undertreat pain due to fear of overdose and feeding addiction. Now, all of us are afflicted with this condition to some extent or another. And well, we should be. These medicines have serious risks and measurable adverse effects every year in the hospital. But I think we really ought to be thinking about managing pain aggressively in these patients, because there actually isn't compelling evidence that using narcotics in the hospital in a patient with opioid use disorder leads to relapse or worsens their addiction in some way. In fact, we have some suggestion that the opposite is true, that the stress associated with undertreated pain, undertreated withdrawal symptoms may in fact lead towards greater relapse rates. And so as we think about treating pain in this patient population, I think the message really just has to be, if they're painful, address it. And using all of the same types of medicine that you might in a different patient population. Because I hope I've convinced you at least, withholding narcotics is not the treatment for opioid use disorder. And so thinking about that as we manage these patients, I think, is important. So what about patients already taking buprenorphine? So this is a complicated situation, so I'd like to spend a few minutes discussing it in detail. The take-home message really is, if they're taking buprenorphine and they come to the hospital in acute pain, continue it. Split it up to 3 times a day. Think about adjunctive treatments, and if you need to, full agonists will still work. And so to understand this a little better, I'd like to talk about a little pharmacology. So here we have plasma concentration plotted over time after that dose. And it turns out buprenorphine distributes quickly to the tissues and then kind of leaches back into the serum over time. And so what this produces is a very high peak right after that dose goes in, and then a kind of slow, steady state over the rest of the day. And as it turns out, you really only get your analgesic effects during this peak. And that's why splitting the dose to 3 times a day can be effective in managing pain. Of course, understanding that the potency is going to be limited to some extent because of tolerance over time. So again, full agonists work. And so to understand this, let's think about our graph again with opioid effect over logged dose. So somebody who's taking buprenorphine is existing here at the ceiling. But keeping in mind that there's competition at that mu receptor, just like any other agonist. And so you can, in fact, outcompete buprenorphine with high-potency opioids like hydromorphone, like fentanyl. And you can break this ceiling and get some additional analgesic requirements, some additional analgesic effect above this ceiling by using full dose, full agonists. Understanding that because of this, you're probably going to need to be using higher than typical and higher than comfortable doses to achieve analgesia. So this is a complicated situation, of course, and I would call your attention to this website, projectshout.org. This is put together by a group at UCSF. It targets hospitalists especially, and they have a lot of really helpful guidelines, detailed pathways about how to manage pain, a lot of the ins and outs of this topic. And so it's an excellent resource, and I would call your attention here. They actually operate a warm line about 16 hours a day. I dialed that number a couple of weeks ago, and I was on the phone with an expert with detailed knowledge of regional policies within 5 minutes. And so it's really an excellent resource to get some of these questions answered. So the last thing I'd like to discuss today is, how do we avoid gaps in treatment after discharge? As we've already mentioned, you have to have a special license as an outpatient to prescribe this medicine, and so it takes some additional work in the hospital to set folks up for that kind of treatment. And so I'd like to talk about that a little bit. So firstly, providing medications at discharge. One thing that's important is patient education. As I mentioned, this medicine is sublingual, and it turns out that it doesn't work if it's swallowed or not taken properly. And so it's important to spend a little time educating patients about how to use this medicine properly and make sure they understand the follow-up plan so that there is no gap in treatment. So if you don't have an X license, that's the waiver that you need. I mentioned it's legal to prescribe up to 72 hours at the time of discharge. And so ideally, that will provide enough time to establish follow-up with a provider who can continue this treatment. Of course, if you do have an X license, you can prescribe as much as you want, but generally 5 to 7 days is what's recommended. So this was a graph from our very own Mari Kai, Brinty, and Clark, where they're showing the number of X-licensed providers from 2015 till 2017. This was the period where they were doing this outreach to other Providence clinics. As you can see, we went from 5 to better than 40 clinics who are prepared to prescribe this medicine, and that number is well higher than this now. So there we have a lot of resources here in the Providence community to continue this kind of treatment. And so I would call your attention to the new patient call center. This is something the patient has to do. They're going to take a little intake. They're going to reach out to clinics and get these folks scheduled with them. They actually have a workflow, especially for new SUBOXONE starts. There's been about 15 providers in the Providence community who have expressly indicated they're willing to take on new SUBOXONE patients. And so this is a nice starting place to try to find a prescriber on the outpatient side. I'd also call your attention to the SAMHSA website. They have a practitioner locator where you can type in a zip code or a city and it'll bring up all the waivered prescribers. And I operated a little search here within 10 miles of Portland and brought up a ton of providers. So this is something that is a nice little tool for us to use. And the last thing I would mention is Recovery Northwest. This is a group doing tremendous work. They have a location on 82nd Street here on the east side. They also have a location in Tigard. And they have a really full range of services for patients struggling with addiction. And they have prescribers who can continue buprenorphine. They actually operate kind of a bridge clinic. And they can advertise often next day appointments. And so if we're not able to establish follow-up with the provider, this is an excellent resource, this is an excellent place to get some of that bridge therapy as we're contemplating long-term treatment. So, in summary, there's a few things that we can start today. One of them is to reframe how we think and how we talk about addiction. I think I've touched on this several times now, but I just can't emphasize this enough. Recognize that hospitalization is a reachable moment and one where we can really do a lot to reach these patients who are highly vulnerable and often not engaged in the system elsewhere. I think we can add buprenorphine to our toolkit. It's relatively straightforward to use and plenty of help is available. And I've listed some of them here. So the SAMHSA website, of course, Project Shout, we have a UCS warm line, and then of course we have our very own addiction consultations here in the hospital. So thinking about Jason and how perhaps I can have treated this different the next time he comes to the hospital, which I think we can all expect will be soon. Firstly is to have a conversation about addiction and addiction treatment. This is not something that I recall doing at all, and so even just having that conversation I think could go a long ways. I think it's important to manage withdrawal more effectively. I think it's clear that he was very painful, very symptomatic, and because of the limitations that I've described, he was not well managed. And so it's not perhaps surprising that he decided to discharge against medical advice. And so for that reason, I think buprenorphine really rises as a potential way forward for someone like Jason, as a way that we can not just manage his symptoms better in the hospital, but set him up for improved long-term recovery. So with that, I'm happy to take your questions. Yes?
Thank you very much for this information. As far as an outpatient, what is the average cost that a person would incur to go to these weekly meetings with providers that are allowed to prescribe this medication?
So the question is about the cost to patients to get this kind of treatment in the outpatient. You know, it turns out that most insurances are covering the medicine and it's relatively inexpensive. In terms of the meetings that you're talking about, I presume you're talking about some of the social support and the group therapies that are done. I don't have detailed knowledge as to what that might cost, but it turns out that's not a requirement. The requirement is that as an outpatient provider, you need to have that available. You need to be able to refer a person to group therapies, but it's not as though they must do them, if that makes sense. And so if it's prohibitive for a patient, inconvenient or otherwise, it's not a requirement. I'm not sure if that gets to your question, but.
Now, I understand that this kind of treatment requires a cash pay for anybody who's using this drug without a prescriber.
You know, I don't have detailed knowledge on that. I don't know.
That's not true. I mean, there are a lot of providers who are easy to prescribe. Even Providence was treated like any other medical condition. He was the inpatient with hypertension. He went to the team for private insurance, whatever copay they wanted.
Thank you. That was Brenton clarifying for all of us that this medicine can really be used much like any other medicine we would use as an outpatient. So I don't know that there's a particular cost associated with it. Yes.
Thank you for coming, and I think this is a subject that needs to be addressed. I am contracted with Multnomah County as a sub-ED outreach, and when I first came here a year and a half ago, I had a lot of pushback from doctors, nurses. Patients would go up on the floor. I would try to go up and follow them, connect them to resources, services. Sometimes they were like, "The patient isn't here. Who are you? What are you doing here?" But over the last year and a half, I can say that the attitudes have changed because they've seen the work that I'm doing in the ED with patients. And some patients have been here like 300 times in 6 months. They'll go out the door, come back. But if I connect them to resources, SUBOXONE, Detox, outpatient, inpatient, we won't see that patient for another 6 months. And like you say, once they've been connected, they're more likely to go and seek help again. And I've seen attitudes change in the ED where doctors and nurses are like, "Michelle, get in here. We need you." I'm in New York State and people are calling me, parents. Not only do we need to connect with the patients, but I've been working with a mother for about 3 weeks. Kids are on their parents' insurance till they're 25. So oftentimes you have to go through the parents' insurance to get them connected. I got this mother connected to an outpatient. That didn't work. Got her connected to a residential program in Vancouver. He had an episode of mental health. I got him connected to some mental health. She calls me and she always uses me as a soundboard. And she's like, "Thanks for being there for me. I just need somebody to help guide me through this system." She said, "Am I being a little aggressive?" And I said, "No. If it was my son or daughter, I think you're being assertive. And when you're fighting for your child's life, you have to be assertive." So I understand it took us about 3 years to get in Providence. We've been in Legacy, Good Sam, OHSU EDs, but it took us a little longer to get over here. But now that I've been here for almost 2 years, the doctors, the nurses, the social workers, they see that connecting the resources to these people with issues with alcohol as well as drugs actually saves us money.
Big time.
And saves lives, which is the most important. They save lives. So I work for Cascadia Project Respond, and oftentimes I get calls from St. D's and other hospitals because the social workers over there, they know me, and they call me and they go, "Michelle, I have this patient. Can you help me?" So now Providence has hired outreach workers at other hospitals.
All
One
right.
of the doctors said, "Hey, we need to have a Michelle in every hospital. This works."
Well, thank you, and thank you for the important work that you're doing. Really. Right here.
You presented very eloquently a pharmacologic paradigm to a treatment of a very complex disease. I am wondering if there are any other paradigms being considered somewhere else that may address this disease a little differently than parallel it to a diabetic foot problem, which will never return to the normal
Right.
condition.
So the question was about are there alternative paradigms for treating addiction besides this idea of induction with long-term management? I'm not sure that I've come across another paradigm that's gained significant traction. I think that there's, for a long time, been a thought that people need to be ready to seek treatment, and so centering our care around detox centers and outpatient providers where they're kind of showing up for treatment is perhaps a better model. And then, again, there's a lot of discussion about the group therapies and the other kind of social support components that's important here. And so I think there is a school of thought out there that keeping things on the outpatient side centered around detox centers and primary care is perhaps a better model. Of course, the methadone model would be another, where you have methadone treatment clinics. They come in daily. They have a very structured environment. And there's some speculation, actually, that just having a patient come to a methadone clinic and engage in those structured activities is helpful for treatment retention. And so that would be perhaps a paradigm I would point to, but not as though I see a lot of traction in that direction. Yes?
In terms of monitoring, using SUBOXONE long term, what have you seen in terms of monitoring, as well as have you seen many studies on what the long term effects of being on SUBOXONE? I have a patient who's been on it over 10 years now and can't feel his feet.
Oh, gosh.
No feeling from his feet all the way up to his legs and his hands are totally numb. And it looks like you're doing all of the other workup. The only thing we can come back to is SUBOXONE. So I'm wondering what you've seen in terms of, or if there's any research you've seen with
Yeah.
sequelae for people being on this medication.
Right. So the question is about sequelae of long-term management. There was a thought that maybe there's some neuropathy, it sounds like, with a person treated for 10 years. I don't have detailed knowledge about long-term outcomes. I really don't. In terms of the monitoring that's done, in general, we try to monitor urine drug screens and things like this, just to get a sense for how we're doing with our treatment. And then the LFT question comes in, just making sure that we're not missing new hepatic injury. But besides that, I have not come across important considerations for long-term treatment. I think we're, even though this medicine's been around for 20 plus years, I think we're still just learning about how it's going to behave over those kind of time frames. So I just don't know. Yeah.
Thank you for coming. When you were talking earlier about the opportunity of addressing opioid substance use during hospitalization, it made me think of what we've been using for immunizations. Every time there's a contact with a clinic or hospitalization and immunizations that are due or not given, that's a missed opportunity. I'm wondering if that type of language is in the literature that you've looked at. That's one question. And the other question is, in the STOP study, you mentioned that cycle of relapse and then progress in a relapse. And did they actually, I know there was 134 patients or something like that, did they actually kind of take that substance use history of relapse into account in terms of getting on treatment?
So we have a couple questions here.
Successes of getting to treatment.
So the first question was about do we have the kind of language we see with, for example, immunizations, where each time we touch a patient like that, are we making sure to address immunizations? And have I seen that kind of thing? I can't say I've seen that in particular as I reviewed the literature, but I think there is a general sense that we ought to think about this kind of the way we think about tobacco cessation, that each time is a new opportunity, and that we, taking a few minutes to address it is effective. Understanding that recurrent relapses are going to happen, and that's part of this disease. But no, I haven't seen that directly. Your second question, I'm not sure I quite understand the question, especially, the STOP study you were asking about. It sounds like, did they take into consideration their prior substance abuse history as they're enrolling patients into the study?
In terms of looking at the outcome of becoming on treatment, going into treatment. So if they had relapsed before or if they had been offered treatment in the past, was that a marker for being more successful in getting into treatment?
Yes. So the question was about, is prior experience with treatment for addiction impacting the outcomes in the STOP study, it sounds like. And there was a post hoc analysis. Again, this was not a pre-specified outcome, but in a post hoc analysis, they did look at all kinds of demographic data and other things like this. And prior SUBOXONE exposure was a predictor of success. So I think, much like tobacco or some of these other addictions that we treat, there is some thought that current treatment is the norm. Dr. Jim.
Can you comment on the injectable depot preparations of buprenorphine, and if there's any indication in the inpatient setting for its use?
Yeah, so Dr. Jin's comment or question is about depot injections of buprenorphine, and are we seeing this come into use? So yes, there is some data starting to leak out as to a longer acting form. You can imagine, I the time of hospital discharge. You can give someone an injection and you're covering them for some number of weeks. So the short answer is yes, there is some promising data. It is quite preliminary. We don't have anything prospective yet. But I do foresee a big role for some longer-acting buprenorphine formulations, undoubtedly. John?
So on your bears, you went up with the fear for pain and pain treatment, but I thought we were moving away from narcotics for pain treatment. So what should we use? Like in your patient in particular, a lot
Yeah.
of pain. It's not unreasonable not to give him morphine or fentanyl because it doesn't work very well. But what do you use for those patients?
Yeah.
Instead?
So the question is about, well, we're kind of moving away from narcotics. So what do we propose to manage pain? And so I guess I would take issue with the premise a little bit. I mean, I think that, yes, we ought to be limiting narcotics as best we can, especially in the hospital. But I think withholding narcotics as though we're going to cure someone's addiction by not giving them narcotics is probably not the right treatment paradigm. So I guess my thought would be, if you have acute pain and you're in the hospital, use narcotics if you need it. Again, pointing to some of that data that the stress associated with untreated pain and untreated withdrawal is associated with more relapse. So I would say use narcotics if you need to, carefully and with close monitoring. But I don't think that withholding narcotics is necessarily the best approach in general. Does that get at your question?
Well, then, just to dovetail that, and this is tough because most of us in this room grew up during a time when we were told use the amount of opiates to treat the pain, and then that may or may not have gotten us into where we are right now.
Right.
But so we're given high doses probably in the hospital of opiates, and then it's time for discharge, and then do they get discharged on really high levels of opiates to go home with? And are we, how long does that go on for? As long as they continue to say, I'm having pain, and does it get refilled, and are we shooting ourselves in the foot?
Absolutely.
That's, to me, that's the biggest challenge.
No doubt, and I agree with that that's the biggest challenge. So the comment is about, well, okay, we're using narcotics in the hospital, maybe even high dose, and then what, are we going to contemplate a discharge plan that includes narcotics? Excuse me, how long do we keep going with that, for example? Yes, I think you've clearly identified one of the biggest hurdles to using this medicine in the hospital. But I think in general, the recommendations that I see, and there's actually been quite a lot of work that's been done with perioperative management of buprenorphine and narcotics. And what we found is that patients who are treated with even IV narcotics perioperatively, who are taking methadone, for example, there's no increased risk of relapse, even if those are continued outpatient. So while it's difficult to kind of plant a flag and say, aha, only 5 days of treatment or 10 days, I think, again, managing pain as best we can in the hospital is the best approach. And if you're dealing with more acute pain that can be reasonably managed with buprenorphine, then perhaps that's not the best candidate for that medicine, and you kind of address it down the road. It's a tough situation, no doubt. Nate.
I just want to, so just thinking about that kind of timing of this and the other patient population we see with these things frequently, obviously the IV drug user come in with an abscess and acute pain from that. How do you, I'm curious how you've been managing as far as when would you consider starting the buprenorphine? Do you see some, I know if we're going to talk about 3-day induction windows and things about length of stay, I mean, is that something that you kind of start straight away as they lead into that hospitalization, you know, if they start to go into that initial withdrawal period, the frequent use of methadone, I said recently, should you be using buprenorphine right away? And then how about managing pain with the abscess? I mean, I imagine buprenorphine would give you some relief before using additional opiates on top of that if needed. I'm just kind of curious how you think.
Yeah. So the question is about time course of buprenorphine induction, envisioning a patient, for example, who may be admitted with an abscess or an acute painful syndrome. When do you contemplate starting buprenorphine, and then how do you manage that pain during that period? So that's a very difficult situation. I mean, I think that's the short version. But what I would envision is, you know, if you can have a conversation at the outset, describe buprenorphine and you have a person who's on board with that, then yeah, you can imagine inducing buprenorphine at the outset. Now you're going to have to stop narcotics for a while, and so the patient would have to be agreeable that it's going to be uncomfortable for 6 hours or so. But then you could reassure them that, okay, once the buprenorphine's on board, you get some analgesic effects from the buprenorphine, and then yes, you'd add back on full agonists to try to treat that pain. So the other part of your question was about a 3-day induction protocol. How does that layer with our length of stay and these sorts of things? And so that's another consideration. If someone's coming in, you don't foresee them being in the hospital for days and days, that may not be the best candidate for buprenorphine. I'm not sure if that gets to your question entirely, but I think understanding that buprenorphine is not going to be for every patient. I mean, there's clearly a subset of these folks who it's appropriate for. And methadone may well be the better choice for someone who's acutely painful, who you're going to need those full agonists, additional full dose, short-acting agonists on top of that. I do see a lot of discussion out there about, okay, you start with methadone first, and then you kind of switch to buprenorphine. And that's an even more prolonged, kind of complicated process that you probably wouldn't contemplate for a shorter hospital stay. But if you're stuck with 6 weeks of IV therapies, for example, you can contemplate a methadone to buprenorphine type management approach. Not that I'm aware of. So the question was, are there particular risks to just going straight to buprenorphine? So envision a patient who comes in the emergency department in withdrawal. What's to stop us from going ahead and starting buprenorphine? None, I don't think. You get some analgesic effects, not a ton, but some. So you're probably going to have to do a little bit of work with full agonists on top of that. But I think if you can get to the patient in that moment when they're having withdrawal symptoms at the start of a hospitalization, I think that'd be the perfect time. The trouble, of course, is that they may well get 8 milligrams of IV Dilaudid in the emergency department, and then you're having a conversation about, okay, in 12 hours, what are we going to do? But no, I think that would be a perfect opportunity.
I really like when you were talking about the critical point of the transition from hospital to back to outpatient care. Could you talk about, or have you seen really good models or evidence-based models for that in the literature that you looked at?
Like how exactly we go about that?
Yeah.
So the question is about the kind of process of these bridge clinics, or how do we link folks from the hospital to the outpatient center. So most of the data that's out there, it turns out, are from these big, not always, but typically from these big multidisciplinary groups. Often they have psychiatrists involved, they have a multidisciplinary team, and so they kind of deploy this bolus of support, social workers, to try to get these folks plugged in, which I think is likely the model I see most frequently. Now, a couple of those case series that I showed you, those were not part of big teams. They were not having armies of research staff going in and plugging these patients in. So there is a thought that this can be done by individual practitioners. But in general, what I see most common are these big teams that come in to address this. Amy? Lifelong, right? So the question is about, are there data out there about tapering off of buprenorphine more long term, and kind of how do we address this idea of treating a person forever? So I don't have detailed knowledge about whether or not there's good data to suggest when or under what conditions you would contemplate a buprenorphine taper. I do know that this is done in some people for whom they feel like they don't need that additional support anymore. That would be appropriate. But I can't point to particular data. But not that there isn't, just that I don't know what it is. Thank you. Thank you all for coming.